point. It's so nice to be back again. Thanks. I always appreciate being a part of your community and sharing with you a variety of topics. So this month, we are talking about the science of weight. The topic of weight itself can be kind of controversial, and we'll talk a little bit about that too in some of the upcoming part of the presentation. But this is always a hot topic. I mean, you kind of can't get away from a discussion around around weight, but the approach that I'm taking from it today is more along the lines of this. I want to share with you what it means, especially in the clinical world, but also you as the general population or as a patient, understanding why body composition is different than just weight, how weight can be used in the different kinds of sessions or facilities in your healthcare settings, and also understanding too about what kind of causes can happen weight to shift, whether it's a change in one direction or the other. As I always like to walk through, I'm sure you heard as you were entering into the session that the session is being recorded. As Matthew just said, I keep my eye on the chat, so I might ask you some interactive questions that you can chime in the chat, but we also have carved out some time at the end of the presentation where we can open up the floor if you have questions about this topic or about anything really. That said, I am a dietitian, but I'm not your dietitian, so please make sure that you are following your own medical advice and making sure that you're getting clearance if you have any changes of that with your own healthcare providers. Now, today is a little bit different because the discussion around weight, we might have some discussion about some trigger items like eating disorders. So I just want to clarify at the top here, if you feel uncomfortable or things are a little too sensitive for you, please take this as a trigger or a content warning. And if you need to log off or step away when we're talking about some of those things, please feel free. If we've never met before, hello, my name is Dina D'Alessandro. I'm a registered dietitian nutritionist. I work out of New York City and sometimes in parts of Ocean County, New Jersey, and across the virtual wellness space that is known as the Dish with Dina brand out there on social media. I have a wide variety of training under my belt. I am coming up on, I think, my 7th year of teaching at Lehman College in the Bronx, where I teach undergraduate and graduate nutrition courses, and I'm also the campus dietitian there. I also run a private practice. I do a whole bunch of things. You can kind of see some of the other experiences that I've had there. And like I said before, I'm really grateful because this is a second career for me. I changed up my whole life back in 2013, and so here we are. Gosh, 12 years later, and I'm really loving what I'm doing, and I hope that the stuff that I provide to you also benefits you as well. So I first want to just share about, as a healthcare provider, the stance that especially dietitians take when we're working with our patients is understanding what might put them at risk for what is known as malnutrition. And I'll define that and talk a little bit more about that later in the presentation. But sometimes we do screenings, right? We get to know you at the onset of our sessions. We ask you what kind of foods you eat, what kind of health history you have, if you have access to certain things, facilities, resources. And then as we continue to meet with you, whether it's every week, every month, twice a year, every year, for however ongoing it is, we keep on reassessing you as the patient and the provider. We keep on looking to see if you're at risk for anything or identify certain factors that might put you at risk with your health outcomes. And we also monitor the response to the things that we're working with you as well. So when we talk about treatments to somebody, I could be talking about food modifications. I could be talking about medications that you're taking. I could be talking about setting up goal setting. Like that is technically an intervention, putting you if you were part of last month's meal planning webinar, that is a treatment, an intervention. Did it work? Did it not work? So we're constantly going through and evaluating and comparing what's working, what's not working. The other thing too to keep in mind, like I said, with this discussion around malnutrition is, for an example, if I'm working with somebody who has stage 3 chronic kidney disease, I'm less concerned that they're physically inactive than I am that they don't have access to food. That to me is going to cause more of an issue about helping support their condition and helping make sure they stay healthy, right? Quote unquote, whatever we're defining as being healthy, than them not working out. So my focus for the time being might be to prioritize their food consumption, their intake, making sure they're getting proper quality and quantity of food, and then we'll worry about working out and that sort of thing. So this I share with you just so, again, you can be a little bit more empowered and understand what goes on behind the scenes in a patient setting, and also recognizing that not every healthcare provider has the luxury of spending an hour with you in a session, depending depending on your insurance, depending on, the schedule of people that they have to meet and see over the course of the day. So if you ever want to inquire, make sure you have some information in your back pocket of what you might want to ask to your healthcare providers when you're meeting them. What is this for? What do you need this information for? And what is this going to help me with in the future? So again, I want to share with you too this discussion around body composition. So many people are focused on, I step on a scale and that number indicates and determines everything in my life. But I continually have to tell people, you are a meat sack, and that is the gravitational pull on the earth. You have to remember that there's so many other things going on behind the scenes. There's fat, there's muscle, there's water, there's blood, there's bone, there's organs. That is what makes up your whole body composition. So I really like to remove the focus just solely on the number of that scale and dive a little deeper into the other things that could be related. And I'll share with you too of how that might also play a role with your healthcare conditions. Then one of the last classes I taught at Lehman College, I do every so often, they give me the class, it's life cycle nutrition. One of the things we talk about is exactly what you see on screen here. The two major things that we talk about over the course of our life cycle is that our body just naturally kind of stops doing what it does before a certain age or after a certain age. So on the left-hand side, you're talking about bone density. Our body is creating bone. It's helping it be really strong. Typically around the age of 30 is when that stops happening. And yes, we go through a cycle of what's known as like remodeling, but it becomes almost like our human responsibility to maintain that density or to keep that density happening as we age. And I'll talk about that in a second. On the right, and sorry, to correlate that on the left-hand side, the reason why bone density is so important, it helps with preventing things like osteoporosis, which is porous bone, and also the issue around fractures. As we age, we become a little bit more prevalent in falling and creating a fracture and breaking a hip, breaking a leg, breaking an arm, and then that takes time to heal. We might have surgeries. So we really want to make sure we're reducing the risk of that happening as best as we can. On the right-hand side, we talk about muscle mass, growing those muscles, big and strong muscles. That generally occurs, the peak time of that is around 20 to 30. So here we are, many decades later, we have to actively play a role in keeping that muscle mass active because, again, as we age, it does tend to decline and deteriorate. And muscle mass is important because it helps us with maintaining that stability and that mobility, right? It lets you move around whatever limitations you might have or not have. It also helps with the overall metabolic functioning of our health and the overall strength. So if you want to put in the chat, if you feel like putting in the chat a little pop quiz, when you think of density, what comes to mind as far as vitamins and minerals? What are vitamins and minerals that you think of that get you big and strong bones? If you want to put that in the chat, I'll give you a sec to chime in. And then I'll share a little bit too. That's not necessarily on this slide, but I want to talk a little bit about helping with bone density. Me too there. Yeah, there we go. Calcium and vitamin D, Robin, for the win. Exactly. Yeah, calcium and vitamin D, very important. So let's talk a little bit about calcium. And by the way, if you attended or if you go back to the PSS website when we did the macros, micros, and food groups webinar, I have a lot more information there about these smaller micronutrients, these vitamins and minerals. But yeah, calcium is a big deal. So calcium is usually found, you probably know, right? Milk, cheese, dairy foods, can also be found in soy products, can also be found in plant-based foods like broccoli and sesame seeds and leafy greens. We also have in our food supply something that's called fortification. So say, for example, you buy orange juice. Orange juice doesn't naturally have calcium, but you might buy a brand that has calcium fortified orange juice so that it knows, the company knows you might need that extra calcium. Obviously, we always err on making sure have people who are getting the whole foods of what they need first, but then if they need to supplement with something through fortification or through pills, then that would be secondary for us. Vitamin D, on the other hand, comes first and foremost comes directly from the sun. So if you stand outside for about 10 minutes and get some sun on your skin, that would be great. You can also get it from what we call fatty fish or oily fish like salmon, tuna, sardines, and mackerel. You can also get it from egg yolks, and you can also get it from fortified foods as well. So some, cereal products might have vitamin D added to it. On the left-hand side, the people who are most at risk for issues with bone density because of either a lack of calcium or vitamin D, or if they've had a history of it. Could be people who are not outdoors a lot. So whether you're frail, you're housebound, you're in a care home, people who might have to wear long sleeve or clothes that cover their whole body and they don't get that sun penetrating them. So for instance, if you follow a religious law to cover your body and you're not getting that sun penetrating, you might also be at risk. If you're darkly pigmented, it's a little harder for the sun to penetrate through your skin, and you might also be at risk there too. If you have a previous condition for osteoporosis, if you are menopausal, because estrogen does play a role in helping keep those bones strong. So if you are postmenopausal, then that would be an issue there of being more at risk for bone density issues. And if you are following a vegan diet where you're just getting 100% plant-based foods, no animals, it's possible that even those calcium rich plant foods might not be what we call as bioavailable. So they don't penetrate into our cells as much as the animal stuff. So you might need some fortification or some supplementation there too. So the one thing that I want to bring up is as we age, like I said before, right, that 20 to 30 mark, sweet spot. After that, a lot of things are kind of gradually deteriorating. There's some wear and tear that naturally happens. So not only are we starting to lose some of that muscle mass and lose some of that bone density, but yes, we are also starting to gain some of that body fat naturally. These things occur. And because of that, we end up seeing that that becomes the focus. So in research and in the clinical setting, this is where we now start assessing people. Are you carrying extra amounts of fat, body fat, especially around what's known as the visceral organs? So your viscera is kind of like the abdominal region. So think of things like your heart, your lungs, your kidney, your liver, anything that is in excess around there could potentially put you at a higher risk of things like type 2 diabetes, heart disease issues, and maybe even certain kinds of cancers. Conversely, the muscle mass, so when we're trying to assess muscle mass there too, that's playing a role in things like I mentioned before, your metabolic health, your mobility, functional independence, strength, etc. Let's put in the chat too, what comes to mind when you think of muscle mass? How do you maintain muscles, whether it's food or other things? How do you keep yourself from maintaining that muscle mass? You can put that in the chat if you want to. Let's take a look. Oh, I see earlier red meat. So yeah, meat could play. I don't know if that was the answer to this question or not, but yeah, meat takes a role. Protein of any source is helpful with repairing and building muscle mass. And also, this is why it's really important that strength training is incorporated in your weekly workout regimens, any kind of resistance training, body weight movements that you're doing, you're building up those. Yeah, exactly. Carrying heavy groceries totally plays a role in that too. Exactly. Thank you. So again, I'm going to keep saying that even though we focus on a couple of things, we still want to be mindful that we're looking at a bunch of different stuff when we take a look at the overall health conditions or health outcomes of somebody. So aside from just stepping on a scale, the other ways that we can get in the clinical setting, other ways that we can get a little bit more of a deeper dive into what your conditions are, or if you might be at risk for things, is we might do an upper arm circumference measurement. So if you are in a chair-bound condition, or if you are losing a lot of muscle mass post-surgery or whatever, that can also give us an idea where we actually physically put a tape measure around in between your shoulder and your elbow, and that can indicate if there is some muscle loss there. We can also do something called a bioelectrical impedance analysis or a DEXA scan. So the DEXA scan is actually one I want to talk a little bit more about. Some some facilities like a healthcare center or a clinic might have a DEXA scan. Some hospital settings probably do. Diagnostic centers like radiology centers probably offer DEXA scans as well. A DEXA scan is known as the gold standard. And when you hear that, what that means, it's the most accurate method for assessing and measuring body composition as a whole. So it's not just giving you the weight, as you can see there, somebody's kind of going through this like open MRI looking machine, and it's giving a whole scale and scan on everything that's going on underneath, bone density included. That said, sometimes these are not covered by insurance, even if you're getting a referral to get one. So you might end up not getting one at all, but if you fall into any of these categories that you're seeing on screen, that might be a good encouragement for you to speak with your healthcare provider to see if you might need one. And that would be women age 65 and older. I think that's because we just assume you're probably postmenopausal, or again, like I said, you know, after the age of 30 with the bone density going down anyway, as you get further away from that age, you're more at risk for things like that. Postmenopausal women who are under age 65, so I would be in that category there. Men age 70 or older, if you have a history of falls and fractures for sure, and if you are receiving any conditions or treatments that can affect your bone health. That can be people who are dealing with rheumatoid arthritis. If you're dealing with chronic kidney disease, there can be some issues there that are related to bone health too. If you're taking medications like steroids, that can also impact your bone density. Not on this slide, some additional risk factors could be family history of the disease, if you are a smoker, regular smoker, if you drink alcohol excessively, or if you are just naturally on the low end of body weight. Again, because if we're using that kind of indication that you probably might have less body fat and less muscle mass, we want to make sure that your bones are being protective. So here, I didn't have time in today's presentation to go deep into the whole discussion around calculating calories or understanding all the calculations that are used in these assessments that we do with our clinical settings and also in the outpatient stuff too. But one of the things that we take into account that is related directly to the topic of today's webinar is how we calculate weight. How do I know how much somebody quote unquote should weigh? And so I do see some stuff in the chat, so I'm gonna check in that in a second. But to clarify here, again, understanding the terminology when we look at ideal or recommended or guidance around, this might be very different from person to person because just as you saw before, there are so many different factors that are involved that influence somebody's body weight. But in the textbook world, like when we're studying this stuff, we're told that an ideal body weight for males and an ideal body weight for females are based on this calculation that you see here, 106 pounds for the first 5 feet, 6 pounds for every inch over that. Then if I give you an example for, say, a 6-foot tall male, and I do the calculation, the ideal body weight for that person is 178 pounds. For the example with the female, different number starting 100 pounds plus 5 pounds for each additional inch. A 5'5" tall female is about 125 pounds, quote unquote, ideally. We do sometimes add or subtract about 10% from this, depending on if somebody is a smaller frame size body or a larger size body. But I'm going to share with you here very openly that I am about 5 feet 4 inches, and I've been probably holding steady about 140 pounds for about 20 years now. So if I were to go to a healthcare provider and all they did was say to me, well, you're like 15 pounds overweight, I physically, unrealistically, would never be able to meet this quote unquote ideal number. I don't think I've been 120 something pounds since I was like 11 years old. Like that's just not how my body is. And I'm not a small or a large frame. I'm a medium-sized frame. So I'm an average sized body that just happens to be 140 pounds because of how things are situated on this, again, this meat sack of mine. So it is unrealistic for me to have to strive for that number. And this is why I like to just drive home that sometimes what you see on these labels, these categories, these classifications, and what you might be looking up on Google sometimes doesn't necessarily mean it is unique, or I should say a generalization for you. We want to make sure that you are getting the most individualized approach and treatment for yourself. So I'm just going to compare this here on the second slide. When you see things like the Hamwe method or the Hammond method, that's usually named after a physician or somebody who invented or discovered this. So this is just the metric version. So if you use more metric stuff, I kind of did conversions here. Give or take, it's about a 3-pound difference overall, but it's about the same. So again, the male and the female examples here are similar to the imperial method. Donna, I don't know if I can answer that directly. That would be something. So you're talking about HRT, which is hormone replacement therapy, too late to start in your 70s. My understanding is it's probably never too late to start anything, but it's a matter of how effective it might be and what other potential issues or complications or side effects could happen that as we age, we might need to just take into consideration. So I would definitely say, take a conversation with your healthcare provider or with your OBGYN to have that conversation, or if you work with an endocrinologist, because again, it's hormones. So making sure that you are they're meeting the needs of whatever you need. Yeah, I don't know if I would be able to answer that necessarily. So yeah,
Yeah,
Robin.
okay.
Yeah, you're welcome, Donna.
Okay.
Yeah. Thank you. Robin, yeah, but the bone density scan, that DEXA scan is exactly that. So it's a bone density scan, but it also takes an overview of literally everything, like all body composition. And the readout is very intense and specific, itemized. Like it'll say, 13% organ weight, 37% body fat weight. So it's a whole scan of your body, and within that is also the bone density scan. So thank you for that question. Yeah, so let's talk a little bit about this too, right? Like I just got done saying, humans are very complex. We're very complicated. We're not a one size fits all anything. And so for healthcare providers too, that is how I was trained as well. I was trained with the textbook that gives me very pat very specific instructions that are one size fits all. But when I worked in and I became a qualified, credentialed dietitian, and I worked through my counseling sessions as well, this is where we start learning that every person is unique. I can't just, spit out a meal plan and be like, this is for everyone. I have to really take into consideration such a wide variety of things, and also acknowledge that body weight is influenced by a ton of different things. Like you just saw, a lot of things can affect your body weight, including genetics, including environment. And if you've attended any of these webinars before, we always talk about the social determinants of health, meaning, do you have access to quality healthcare, affordable food? Are you on medicine? Are you stressed out? How's your sleep? There's tons of things, education, literacy, there's tons of things that can affect overall life habits, and in effect then can also affect the body weight, because it's very, very directly correlated with that, the things that can influence that. I also want to mention too that, culturally speaking, across the globe, we see that some people just have different preferences for different size body types or sizes that can correlate not just to nutritional status, but also other things as well. So as an example, I work at Lehman College, like I mentioned. I used to teach a 200 level class called Food Society and Health, where we looked at global foods and societies within the cultures there too, different traditional meals, etc. As a comparison, somebody in Shanghai, and by the way, I had a ton of diverse students, so they would give me feedback on their lived experiences too to confirm what I'm about to share with you. So, for instance, somebody in Shanghai, we're talking Shanghai, China area, Asian area, women are sometimes expected to be very slim, very slight, very dainty. It's a direct correlation to how they're viewed as, feminine and demure. Whereas a place like Jamaica, having more, quote unquote, meat on your bones means that you are a symbol of wealth and power and fertility, right? I don't want some skinny person doing any of this. I want somebody who's got some meat on her bones. So again, this is that also need, especially in the healthcare world, for us to really be sensitive towards the cultural conversation too. If somebody has a status of my body size equals whatever, and I'm telling you need to add or subtract weight to your body, that is going to be very closely tied to your identity, just like your food would. And we've talked about this too in some of the other webinars. I'm not going to tell you to stop eating rice. Rice is a global staple food, and it is a huge part of a lot of people's traditional food ways. So I have to be very sensitive to when I'm talking about modifying or healthifying people's approaches, that I take that into consideration too, much like I would with people's body sizes and weight. So on the next two slides, I just want to share with you the tables that we use in the clinical world. So when we're working with children, and by the way, the pediatrics population is technically from ages 0 to 20. So we're talking fresh out of the oven to, just about to be done with college. We're quite literally plotting their height and weight and age and all of the different things on a graph, on a growth chart. And then we categorize them into percentiles. And we do this because we want to make sure that there is a proper trajectory. And yes, kids have growth spurts and they might get sick and maybe they don't fit within that curve, but that's just here and there and very isolated. If we notice patterns of spikes and dips, that can really give us an indication that something underlying has to be addressed, that there's either a possible risk for malnutrition or there's a cognitive or motor skill issue that has to be addressed. And we work with the pediatrician or the therapist, occupational therapist, speech pathologist, etc. So that is the children's view of the percentiles. Now, this you might be more familiar with. Sorry if it's a little bit blurry. This is the body mass index. This is the now adults at 21 years and older. This is the classifications that we use as an estimate of measuring body fatness. And it's only based on two pieces of criteria: height and weight. That's it. Nothing else is involved in there. So it does not take into account all the other things that I mentioned. It doesn't take into account muscle mass, bone density, body composition, ethnicity, race, age, none of that. And if you can see here too, in that middle category of 25 to 29.9 in that overweight classification, we have research has shown, and in the clinical settings, when we work with people in the ages of 65 and older, if I see somebody categorized as 25 to 29.9 BMI overweight, it's actually more of a normal classification for them because we take into consideration what I mentioned before. By nature, our body is slowly deteriorating. We're losing bone density, we're losing muscle mass. So it would behoove us to allow a little bit more of that leeway to happen and provide the older population to have this kind of curve on the BMI classification. So if we're only using height and weight and we don't know all the true behind the scenes body composition stuff, when I look at a chart and it's giving me the calculation of quote unquote overweight for a person aged in the older population, 65 or older, in my brain, I actually switch that. So now I go, okay, that's more like a normal weight. And then everything else gets pushed to accommodate the classifications accordingly. Okay, controversial topic about BMI. It is a very outdated and a very flawed measure, and maybe at one point I'll go a little bit deeper in it, but it is rooted, unfortunately, in eugenics. It's not created by anybody who was involved in healthcare. It was done by, I think, an astronomer, or he was like some sort of statistician. And again, he focused on this quote unquote ideal body size. And it's very hard to figure out how we make everybody ideal when we all have different ways of being born and growing up. So I really want to be conscientious of my language here, but it is, and I've talked to a lot of healthcare providers about this, it is lazy medicine if all somebody is doing when you as a patient walks into their office tells you you have to lose weight because your BMI is whatever, or they share with you the classification of your BMI and that's all that they're talking to you about. But that said, like I said before, I acknowledge that it's not very easy for a lot of healthcare providers to get into those nuanced areas of, or maybe they might have the time to share with you. So it is continuing to be used widely in medical communities because it's inexpensive. It's a quick way to, analyze somebody at a glance. But I really want to be careful with this because I have seen, even just the 9-ish years that I've been a dietitian, it causes a lot of harm. A lot of people get really caught up in this number thing, and we'll talk a little bit too coming up about how in the healthcare setting that can be an issue. Yeah, thank you. Thank you, Robin. Exactly. So I'm going to share with you here, again, taking that word, that classification of obesity. What does that mean? And by the way, I just realized that this picture, the top, the women, they are actually in a like pinkish colored bathing suit. They are not naked. So I'm sorry if it looks a little awkward that they're topless. They are not topless. They are wearing pink colored bathing suits. And the guys on the bottom are wearing blue colored bathing suits as well. So this here too is why this is a little confusing because we just got done saying BMI is height and weight. That's it. They classify you as obese. Okay, fine. That means that you have a high BMI of 30 or higher. But obesity is also, or could also be classified as an excessive body fat percentage, 25% or 30% more, depending on if you're male or female. Or it can also be defined or classified as obese if you have a larger sized waist circumference when they're, measuring around your abdomen, that area, that if it's larger than 40 inches or larger than 35 inches, whether you're male or female, that could be termed as obesity. So again, it's very confusing to sit there and just say it's one thing equals obese. And this is why, again, we can't really utilize this as the end all be all. So I'll give you kind of a visual representation of everything I've just been talking about. On the left-hand side, you have a sumo wrestler. On the right-hand side, we're going to call him a competitive bodybuilder. They're both 6 feet tall. They both weigh 250 pounds. And they both clock in, if we do the calculation, for a BMI of 33.9, which is obese. Now, we could argue, right, the guy on the left-hand side has a ton of fat and the guy on the right-hand side has a lot lean muscle. And I could say to you, social constructs indicate that the person on the right would be deemed more healthy. But I could also say these are people who are training for like very competitive, performance-based, athletic positions, right? They do a lot of sports stuff. This is still athletes in front of you that you see here. And I could also argue that the person on the right-hand side, to get to where he needs to be in that bodybuilding position, he could be doing steroids maybe, or just the amount of exercises that he's doing in his weightlifting training could build up so much muscle and could decrease so much fat that he actually ends up having poor tendons. He can get tendonitis a lot, and it could also mess with his reproductive health because we need body fat to help us make the hormones to make sure that we have a good reproductive system. So again, coming to this discussion that we've had in a lot of these past webinars too of how we define health, thin doesn't always mean biologically, or I should say metabolically healthy, and fat doesn't always mean metabolically unhealthy. So we have to keep on digging and diving a little bit deeper into the overall issues that exist. And yes, sometimes there is a correlation, which I'll talk about in a second, about body sizes, body weight, fat, and muscle, but it's not just the one thing equals the other thing all the time. So I'm going to finally now share with you here this word malnutrition. I think what happens a lot is when people see this word, they think of like the skinny, emaciated kids on TV from, Africa who don't have enough food to eat. But malnutrition, M-A-L, means poor or bad. And if you remember the macros, micros, and food group webinar that we had a few months ago, I went in a little bit deeper into all of that about the quantity and the quality of people's foods. So if I am, going back to that very first slide at the beginning of this presentation, if I am, as a healthcare provider, assessing you and your risk for malnutrition, I'm looking to see everything. Because you could be eating enough calories, right? You could be eating 2,000 calories a day, but is it quality food that you're getting? Are you getting the proper vitamins and minerals from it? If not, then you're going to be deficient in, and you're going to have poor nutritional health because you're not getting the quality of the food. Or you might be eating a decent amount of vitamins and minerals, but you're not getting enough because you don't have access or the money to something in order to purchase the food that is health supportive for you and nourishing for you. So this is why that word malnutrition is really on this spectrum of things where it could be a whole bunch of unique different factors that affect this. And ultimately, again, what is perfect in anything, but the whole point is to make sure we take you away from being at risk for being malnourished in that sense. All right, so now I'm going to share with you some of the research that does show this correlation about weight and as a predictor of health. Now, as you can see here on that first bullet, there is a correlation of increased risk of chronic disease and even premature death. But do you see what's there? It's BMI on either end of the spectrum. So you could be underweight or you could be overweight/obese and still have the same, statistically speaking, be still at the same increased risk of having type 2 diabetes, heart disease, or dying early. But yet, and I think you might agree with me, we only ever really see conversations around people in the higher BMI. We don't really ever acknowledge people in the lower BMI. And that's because, like I said before, socially speaking, people in larger bodies are sometimes looked at a little bit as it's unhealthy, and people in smaller sized bodies are applauded. So it could be like, yay, you lost 30 pounds, congratulations. But maybe they got that way in not the best situation. And I'll talk about a little bit more about that coming soon. The second point there is if you do have conversations around weight reduction, and if it is something that you're voluntarily looking to do to, get rid of your high cholesterol labs or lower your blood pressure, again, a lot of different factors play a role, but you don't have to lose hundreds and hundreds of pounds to kind of get out of the danger zone. So if you're struggling with weight management, even something as little as about a 5 to 10% reduction, if you are in the higher BMI, can take you out of that danger zone. So we've seen some good positive outcomes from that. And again, depending on how you're doing it, that's always my concern. And my concern is also making sure, as I'll keep saying this over and over again, that is not the only diagnostic tool that we use, because we don't want to keep going back to saying things like, people who are thin are healthy and people who are fat are not healthy. That is not true. The other thing too, I have a note here that in 2016, there was a survey sent out to about 1,000 medical professionals, doctors, nurses, et cetera, people in hospital settings and clinics around the country. And about 40 to 50% of them admitted to holding negative attitudes about people in higher weight bodies or larger size bodies. So this is what is known as weight bias, weight stigma, or weight discrimination. And it ends up creating an unfair treatment towards people in those larger or heavier size bodies. So that can include things like doctors or healthcare providers will spend less time in a session, right? In and out, we're done. They could also have less of an emotional rapport because they might be thinking some negative things, and I don't want to, make a support this person in that way. And they could also deny treatment for a variety of reasons. They could either refuse things like elective surgery, like knee surgery or knee replacements or hip replacements, until the patient loses weight. And again, who knows how long that can take? That person might end up having a worse situation, exacerbate their condition while they're trying to meet that number on the scale, or any other treatment or medication that might be provided based on what their current weight is. They could also be denied treatment or diagnostic tests because their body just doesn't fit into a particular machine or a piece of equipment. So again, there's some issues around, not having accessibility to things. Like, what do we do? As I said before, if you're chair bound, we can take a measurement around your arm. So if you're in a larger size body, how do we help you get that treatment so that you are getting the help that you need? And I keep saying this too, right? People in smaller size bodies. So if somebody does meet the criteria, like, okay, I came in, I came back, and I lost all this weight. Thank you. That's great. We applaud you for doing that. But how did you get there? Like, did you have restrictive diet? Was it very extreme? And, again, I'm always concerned about that too, of how that might affect somebody because of what you're going to see on this next screen. Yo-yo dieting. This is what that used to be known as. Technically, it's called weight cycling, where you have these repeated cycles of lose 50 pounds, gain 40 pounds, lose 25 pounds, gain 35 pounds. Whether it's for treatment, medical stuff, or, I want to be beach body ready, or my daughter's getting married in October, or I did a horrible thing to myself over the holidays and I'm back on track come January 1st, where I'm going to pay attention to my diet and start working out more. But we're doing it, right? The patients or the people are doing it in a way that is unsuccessful, it's unrealistic, it's unsustainable, they can't maintain. So they keep, again, going up and down and up and down. And that in turns puts you in metabolic stress. So this is why, again, the language and the way that you're treated in a doctor's office, if all you're being told is you got to lose 30 more pounds, you got to lose 15 more pounds, and you're doing it, but then, you know, going back up and down like that can also affect your hormone health, your metabolic health. You could also end up being more at risk for things like type 2 diabetes and heart disease, all the things that you're trying to do, or I should say, stay away from because you're chasing the weight discussion. This also is an issue because, just like I was mentioning before, doctors or healthcare providers sometimes will overprescribe weight loss as a treatment when they really have to be careful of that. Sometimes it's not necessary, and it's not the, like, you go for a cold or you have a broken knee. Please just treat me for the thing that I'm coming in for. Let's not talk about the weight stuff. Because again, right, this leads to these triggers. If you're starting with this negative, you're already maybe having negative self-talk, and now you're having somebody who you deem as an authority figure in the medical community who's talking to you down or has a bias towards you. And again, the positive negative discussion aside, it might affect your self-esteem, you might feel body dissatisfaction, and it can then exacerbate. So this is, as a healthcare provider, this is where I'm really concerned. If I work with people who tell me my doctor told me I have to lose weight, my first question is why and how? Are you doing it because you're starving yourself? Are you over exercising? Are you popping pills? Are you on like a juice cleanse? Like, what is it that you're doing? Because those things are technically indicative of a mental health disorder called eating disorders. So we want to make sure that we focus also not just on the physical person, but the mental person as well. What are we doing to help support you get to where you need to go? Or maybe just, address overall things that are causing these habits to happen to begin with. Does it matter how quick the cycle is? Not necessarily, Matthew, but just like anything, it's the pattern. So if it's like once in a while, not a big deal, but over the course of, say, 10 years, if you've gained and lost 20 to 30 pounds or a certain percentage of your body weight in a certain amount of time, then that is what we sometimes classify as either significant or severe body weight change. So again, it depends on the person, it depends on how much, and just like anything, right? Like one cigarette might not cause cancer, but a pack of cigarettes might not cause cancer. So where is it when we start noticing? So that can be an individual thing that happens where we see certain weight cycling happen when we start noticing, okay, your cholesterol is being affected, or all of a sudden you're showing up as a pre-diabetes is coming up on your labs, and yet you lost this weight. It might be because you kept gaining and losing and gaining and losing, and you've really taxed your system in that sense. So here's where I want to introduce you to something called Health at Every Size. If you've never heard of this before, it's just an approach, a set of principles for healthcare providers and for patients to understand. By the way, I also want to note, because sometimes people will say things, people who are a little bit curious or nervous about this approach, they'll say, we're glorifying obesity, and that is not, it's not healthy at every size. It's health at every size. All we want you to do is have a human right to be treated fairly and to do no harm to you, right? We want to make sure we're providing you with quality healthcare. We want to remove any stigma or any bias when you walk into your doctor's office, and we want to make sure that we are supporting you in that way. So it's not trying to force a healthy condition on somebody regardless of their weight, because we just said anybody from either end of the spectrum could suffer the consequences of being at risk for something. It's just about being human and giving you the quality care without any stigma or any bias. And so if you are uncomfortable getting weighed and measured in your doctor's offices, and I'll talk a little bit in a second about why you might need to, but you can decline it. You can say, no, thank you. It makes me uncomfortable. Or you can ask, like, why do I need to be weighed? You can also say, don't tell me the number. I'm going to get on the scale, or I'll step on it backwards. You can write down whatever you want and it's fine. On the healthcare and the provider's end, we just document this. Patient declines to be weighed. Totally fine, not a problem. So if you feel comfortable doing that, you have the right to do that if you want to do that. You can also check and see or look up if you have access to providers who take what's known as a weight inclusive approach versus a weight normative approach. So weight inclusive approaches is exactly what I was saying before. We treat people like the patients are. It's a patient-centered care. My job as your provider is to support you, but you have all of the things that you need to tell me back whether something is working or not. I'm not forcing anything on you. I'm meeting you there, and you play a role in this relationship of your health outcomes. So if you need resources, I give you resources, but I also don't force anything that is specifically, in this case, weight based. So we also try to make sure that we undergo trainings of reducing that stigma. There's tons and tons of webinars, and even in classroom settings too, like what I teach, we have a lot of discussions around this too, of being very conscientious of the language we use and making sure that we take away the whole thing that BMI is the end all be all. And that's the thing that's directly related to health outcomes, because we're seeing that it is not. It's being questioned a lot in our field. And even now, as the general population is learning a little bit more about that too, I'm always, even for myself too, when I walk into the doctor's office and he tells me things about my cholesterol, my blood pressure, I'm like, yeah, and what does that mean? Like, I make him explain to me what this means in the long run. Am I going to have to start taking medicine for this? Okay, so how far before like, what's the danger zone there? How far do I have to go? Or are you just telling me this because it's part of the data? So the more empowered you could be as a patient, the more questions you might want to feel comfortable asking. I hope that that's what this conversation is helping you with. In the research-based world here, when we compare the approaches for this, the critical examination indicates that the weight normative approach is actually not good. Like, the evidence does not show that that gives you a better way to have healthier outcomes. You think of it, like I said before, these extreme measures like boot camp mentality. I can scare somebody into doing something, but it's not going to be sustainable. It might not be realistic, and it might not really get them out of the danger zone if it's something that they're doing because they're afraid. Also, they might not come back to me. They might be like, I hate working with that person because she's always yelling at me about my weight. And I'm so tired of, this is something I've been dealing with since I was 7 years old. And, I don't want that to happen either. So that's why I keep saying we have to be really careful of our language as healthcare providers to our patients, and also empower our patients to have questions that they can answer back, or ask back, I should say. All right, let's talk a little bit about, when is it medically necessary for us to weigh you? So in the clinical sense, we might have to get a measurement from you when you're receiving certain medications or dosing purposes for anesthesia, if you're going under operation treatments or surgery. If you're pregnant, you're going through the cycle of pregnancy, we definitely monitor that too, because there's different phases of the pregnancy that we want to make sure things are acting accordingly, both in the pregnant person's expansion and also in the fetus development too. If you are recovering from eating disorders, if you're in an in-treatment program, again, they're probably going to take weights and measurements too. And I'll talk a little bit too more in a second about certain treatments of organ issues like kidney or lung issues. But again, you can decline, like you can decline looking at this, right? They might need to say like, we need to weigh and measure you for this, but you can easily say, I'm going to turn around, or just don't tell me what the number is if you're uncomfortable. So during pregnancy, right, we monitor weight here. So people will be measured around their abdomen. They'll get sonograms done. We can see amniotic fluid shifts and how the fetus is developing. There's different blood systems, etc. All the stuff that's going on behind the scenes. We even for people in larger size bodies who are starting out at the higher end of a BMI who get pregnant still have to grow. Like there still is a baby being formed in there. So they still have to be weighed and measured and monitored. And here, what I want to share with you is stuff like this. So if you are undergoing congestive heart failure issues, kidney issues, liver, you might have heard the terms either edema or ascites. So edema is just the collection of fluid that sometimes lands in, usually we see that in the feet, in the legs, and the swollen ankles, that sort of thing, but it can really affect any part of the body. Ascites is more in the abdominal region. So again, if I'm noticing weights and measurements and we're comparing things from 1 week at a time, or if you're inpatient receiving treatment for something, for burns or surgery or sepsis, this is why you're being weighed and measured, because we're taking comparisons. So over the course of a week, if you're shifting up or down a certain percentage, again, we're indicating that in our charts that this is either a significant or a severe situation that has to be monitored or addressed. Let me just take a quick look. Donna, once again, as I always tend to say, I hate having to give this answer, but it depends. How healthy is bariatric surgery is the question. If it is something that's going to save somebody's life, like if somebody's been trying very hard to come away from dieting, or they're just having issues with other health conditions, it can be a life-saving surgery. But the way that it is approached is really, really particular, and we have to be very careful because there is a psychological association with that too. The both pre-op in preparing for the surgery, like some people will have to actually gain weight to meet the criteria of getting bariatric surgery. So if that's the case, that could mess with their mind a little bit of like, I'm already in this large body, I'm already getting biased and discriminated against it, and now I gotta gain 10, 15 pounds just to qualify for the bariatric surgery. That's crazy. Or pre-op in anything, like where you're put on liquid diets, or after the surgery too, you're put on very, very strict, specific, somewhat restrictive diets as well. You also might suffer the consequences depending on the kind of bariatric surgery. So if it's like a lap band where they're just pinching off your stomach, not as invasive as doing a whole resection of your stomach or your small intestines, because if that's the case, then when you do eat your food, the way that your nutrients are breaking down are going to miss out or bypass, right? Literally bypass all of the stuff that's gotten taken out. So it won't be able to be absorbed into your body. So you could be then at risk for things like vitamin B12 deficiencies, or other like iron. Different nutrients get absorbed in different parts of your GI tract. So depending on if that bariatric surgery is in a certain place or is a sectioned out, that would end up having to be supplemented. And again, psychological stuff. So if we're, if we're putting the blame on somebody for like, well, you got this big because you overate, how are you addressing the eating habits? It's not just like, I'm going to go for bariatric surgery and this is going to solve all my problems because I'm skinny now, when I still might have a really dysfunctional relationship with food. So I hope that that kind of answers your question. Like, how healthy is it? Again, it depends. It can get people out of the danger zone. It can get people into a safe place that they've been trying so hard to do, and they just feel exacerbated. But it's really about how they're treated before, during, and after. And also, just as an FYI, I don't love this, but the American Academy of Pediatrics approved bariatric surgery for children as young as 12. So consider that too. If you're dealing with a child who has been dealing with obesity, childhood obesity, that's seventh or eighth grade, like they're now going to be maybe suffering some side effects from that, having to prepare, having their classmates maybe now not say great things about them before or after, and then also not be able to like maybe eat or hang out with their friends and do social stuff because they're preparing for that surgery or coming out of it. They have to be really conscientious of the stuff that they're eating. So again, the healthy discussion, however we define health, is so nuanced too, but I hope that that somewhat answers your question. All right, let me finish up with a couple of other things to share with you on slide 31. Let's talk a little bit about the non-clinical stuff, right? The things that aren't as concerning for me if I see changes in body weight that can fluctuate from, say, 2 to 6 pounds a week or something. How often the patterns of the foods that you're consuming, the things that contain high sodium or salty types of foods. When you eat a lot of salty foods, and I think we talked about this in some of the other heart related webinars from a while back, the sodium brings the fluid into the cell. So this is water retention, right? Like you get swollen or super parched, like I have to drink a gallon of water when I eat a pizza or whatever types of foods I'm eating, the pairing up of things of how much sodium my body, reacts to. So that could be something too. I always tell people, if you are being kind of conscientious and weighing yourself somewhat regularly, don't do it every single day. Do it like maybe week to week, because you can have so many different fluctuations. Calories in, calories out is a discussion too. If you're consuming more than you're expending, yeah, it's going to package into what are known, especially with carbohydrates, into what is known as triglycerides. That can actually affect your cholesterol too in the long run, but that packages up as body fat. So you have now these different cells that are maintaining excess body fat, whether it's, under your arms or in your butt or in your legs, wherever it decides to land, that can also add to excess body weight or changes in body weight. If you're consuming alcohol, we sometimes call that, like empty calories. So depending on how much alcohol you consume, that can also affect your liver. So that liver weight would technically probably be categorized more in a clinical situation like cirrhosis. But again, you might see shifts in changes in your body weight there. If you are still menstruating or you have any kind of hormonal fluctuations, if you're on medications with side effects of may cause you to gain or lose weight, again, that could be related to your body weight changes too. Bowel habits, if you're not going regularly, right? If you're putting a lot of stuff in, nothing's coming out, you could be sitting on 4 pounds of poop there, my friends. So that could also play a role when you get on that scale, just like we said at the very beginning of this presentation. When you step on a scale, that's just a number, but all the stuff inside of it, you have no idea what the ratio or the percentages are there. If you do fasting, like whether it's for religious purposes or for your own dietary preferences or caloric restriction, that could also have a change in body weight. Again, we could argue, it might be short term and then you might gain it back, because sometimes that's more like water weight being expelled, not necessarily fat mass being expelled. Or if you're working out a lot or you're sweating profusely outside, that's another way that you can be shedding body weight or body fat. Water weight or body fat can come out through there too. So that could be, something again that you're looking to say, oh, I lost 2 pounds. Well, maybe you worked out harder and you didn't eat as much, or I gained 2 pounds. Well, I didn't poop yesterday and I also ate like a ton of takeout. So that could be again related to some stuff. So, every webinar when I end, I always have this thing where I say, pick something or create for yourself some small short-term goals of next steps for yourself, whether you want to start doing something, continue doing something, stop doing something. I'm not sure exactly how that might apply to today's topic, unless it did resonate with you that you are a patient who has undergone some weight related concerns or didn't have the greatest relationship with your doctor. So maybe the thing that you can start doing is looking for a doctor or a healthcare provider that takes a more neutral approach or really listens to you and provides you with that much needed patient-centered care. If you already are doing good things and you feel like you want to keep doing those good things, keep doing them. Or maybe you stop focusing so much on the scale because you know that there's so much more that's entailing your overall health and wellness. And maybe, you shift your focus on just habits or keeping yourself, right? We did that whole mindful health and wellness webinar a few months ago at the end of last year. I think it was about self talk, negative and positive self-talk. So that could be something you could be keeping in mind if you feel like, you're getting a little bit caught up in the weeds of focusing just on your weight. Then maybe you want to start looking at what other things bring me joy. How can I be grateful? What can I reflect upon?